So welcome one and all, and we will do further introductions as we go through the day. Just before we kick off, a couple of comments by way of my welcome. Just to say that we always assume that board members have read the papers. So when they're introduced, you'll find a very brief introduction, as the purpose of that introduction is merely to draw to our attention anything that has changed since the paper was written, or indeed, and most importantly perhaps, to remind us what sort of conversation the sponsor of that item is hoping to have and what a good outcome from that discussion would look like. So you'll find that they're very brief introductions. You'll also notice on the agenda that we're following through with the commitment we made at our recent board development day to have a focus on the different elements of the CQC well-led framework, and today's focus is on engagement. So just before you get to agenda item 6, you will notice that the descriptors of a well-led organisation in terms of engagement are set out, and we have 3 items that follow that will help us ensure that we have a focus on some of those requirements. The other thing I'd like to flag up by way of the agenda generally is the change to how it is we're going to handle the board assurance framework. The board assurance framework is item 5, but we're going to also make sure that this is the opportunity to have full reports from each of the committee chairs, and those committee chairs in turn will draw to the board's attention any items from the integrated performance report or any items from the risk register that each of those committees have considered in detail, but they deem needs escalating to the board for further consideration. Which brings me on to my last point of introduction, which is you will notice that the board handle a number of items by consent. These are items where there may be a recommendation for approval or some agreement required by the board, but we don't discuss them at the board meeting. And that's because they have been discussed fully elsewhere, and there is an assumption that the board is content with the recommendation unless they bring to the chair's attention that they wish it to be raised in the meeting. I haven't been advised of any intention by any board member that they wish any of those issues to be raised in the meeting. But I suppose I would bring to your attention that some of them are very significant. So the Health and Safety Annual Report is there by way of example, as indeed is our CQC report. So it's not that we don't wish to discuss our CQC report, it's just that we have already, as a board, discussed our CQC report at some length. We have produced an action plan on the back of the recommendations in the CQC report. That action plan will come back to future public board meetings, but it's in the consent item today so that the public may have access to the full CQC report. But please be assured that it has been properly considered by the board and will continue to be so. So that brings me to apologies, and I don't believe we have any apologies today. Oh, sorry, apologies. Zoe Linton is on leave, but we've got a particular warm welcome to extend to Sarah Ward. Sarah Ward is going to be acting Chief Nurse and Director of Patient Experience, but it's also a great pleasure, I don't know if welcome's the right word, but to say hello to Lynn Andrews, who's with us today, and it's her last meeting in that very role. We have had an opportunity, a lovely opportunity, to say a goodbye to Lynn with huge attendance on Teams for that particular event, but of course today is your last formal board meeting, Lynn, and you leave us having established the most splendid legacy in this trust over the last 6 years in terms of patient experience and quality governance and the whole quality agenda. And your successor comes with the firmest of foundations on which to build. So I thank you for everything you've achieved for our patients over the time you've been here. And I would thank you in advance for the further advances that I know are to come, given the legacy that you leave behind, for which we are enormously grateful. And beyond that, Lynn, we will miss your kindness and your good humour, and always having, in my case, somebody right next door to be able to rely on in the way I have. So thank you very much indeed.
Thank you.
I think that brings us now to the Register and Declarations of Interest. The Register of Interest is apparently hasn't transcribed from the register that's on the website, in addition to my Declaration of Interest. That will be updated for the purpose of the board papers, but that declaration is to recognise that as of the 1st of July, I am the chairman of the Chartered Insurance Institute. As I say, the record will be amended. Are there any other changes to the register, or anybody who needs to make a declaration in respect of today's business? I'll take that as a no.
Sorry, Helen, it's Tony Campbell. I do have a declaration of interest. Up until I was a member of the East Midlands Leadership Academy, and just at the point they lapsed, and there's a Midlands Forum being established. So I'm no longer a member of that group.
We'll amend the register accordingly then, Tony, thank you for that. And also I've just spotted the note from Jen Smith. Jen, welcome. I'm glad you're here for Zoe today. I gather you're just back from your maternity leave, so big warm welcome back to you. And as I say, thank you for being with us today.
Thank you.
Very good. John's going to remind me that the meeting's being recorded, aren't you, John?
Yes, that was
it. Thank you, John. The meeting is being recorded. I think when you log on, you do get notified that the meeting's been recorded, and as such, I've given your implicit agreement to being recorded. But just to remind you, it's just for the purpose of getting accurate minutes, but also we post it to our website and to YouTube afterwards in case there's people who would like to understand any part of the business of the day. So I think on that note, I'm going to move us to the board story. The board story today relates to a gentleman who had a stroke, and the story was related to us by his daughter about the excellent support he had from audiology, which we look forward to hearing from. There are also some very delicately, but nevertheless implied criticisms of perhaps the opportunity for further improvement on our stroke ward. And of course, we'll be interested in learning about those opportunities too. So on that note, I'm going to pass across to Sarah.
Helen, I think if you don't mind, I'll just take the introductions. Thank you.
Very good, very good. Well, I didn't know if we were still on the hook for heavy lifting. Thank you, Lynn.
We will do a bit of a combination today, but if I could take the introductions. And Deborah, welcome. Deborah is our chief audiologist in the organisation, and she's on the Teams call with us this morning. She's going to recount the story in brief on behalf of the family, as which you will have just to be aware that they didn't want to be present this morning, given the circumstances of both COVID and their recent passing. So I just wanted to put to you, it's an opportunity for the board to hear from this perspective. As opposed to nursing and patient care, while, as you've rightly said, there are a few issues raised there, but from the perspective from audiology and to bring in other services into the patient story, and that's the opportunity this morning. So if I could hand over to Deborah to just briefly describe the experiences on behalf of the family.
Thank you, Lynn. So I'm going to read the statement out that was provided by the daughter when we explained that we were going to do the story. She initially did send us an email thanking us for our care. So she says, my story about the care my late father was given by audiology whilst he was on the stroke unit prior to his death. My father was 84 and in good health, apart from reduced mobility due to a lifetime of physical activity. He was a lifelong rock climber. His last climb was on his 80th birthday. An ex-physics teacher, a writer, he continued to have magazine articles published until his hospitalisation, and an avid reader of fiction and non-fiction, who read The Guardian cover to cover and completed the quick crossword every day. I say this to explain his lifestyle prior to his stroke and to provide context to my comments. He was an articulate and highly intelligent man who went for a walk every day to keep his fitness. His stroke was a bolt from the blue. He was badly affected by the stroke, and his understanding of anything asked of him or told to him varied significantly from hour to hour. He could answer a crossword clue 1 minute and talk absolutely fancifully the next. One challenge was his hearing. He used hearing aids, and we found some at home that we took to the hospital. As he was 100% self-sufficient, none of the family knew which hearing aids he used or anything much about his hearing loss care. It became apparent to me that some of Dad's difficulties in verbal response and reasoning may have been due to him not hearing properly and not all due to his diminished cognitive processing. After I contacted the audiology service, Dad was visited on the ward promptly and measured for his new hearing aids. They also fitted his old hearing aids, and this made a huge difference to his responsiveness. He was able to speak to us, whereas without them he could not. I felt that he had a chance to come back to us. It is stressful to have your dad so poorly. The ward was too busy for his care to be exemplary, but the fact that audiology services responded to our request and communicated really well with me helped me believe that someone else wanted to help Dad's recovery and give him the best chance. No one on the ward knew him before he was admitted, and he was treated as an old, incapable, disabled and unintelligent patient, as this is how he presented to them. Despite mentioning it multiple times, the ward staff consistently forgot to put his hearing aids in, and on several occasions these fell out of his ears, and we found them in his bedding. It was critical to his participation in his care planning and to his well-being and general recovery that he could hear what was being said. I know this is not a human right as such, but I thought it was a fundamental human need that should have been constantly addressed. The audiology team's support whilst he was on the ward gave him a lifeline that had a huge impact on his recovery. As a family, we supported the hospital carers and stimulated Dad in many ways, and this led to a massive improvement in his condition. He was still very unwell, but he conversed with the staff and his visitors, and we had quite a few laughs. We talked about the climbing photos we took to him and about his life memories. He told me he wanted to go to Wharfdale when he got home. His last weeks were difficult, but he looked forward to visiting, and he talked to his grandchildren online and they to him. We were all there for him, and he could join in because he could hear. We got him using a pen again in his left hand. He made his own menu choices. He could not read well, but we read him the options. He asked for drinks himself, and we had to have some important discussions with him about his wishes for his future, and we would not have done any of this had he not been able to hear us. Hearing was his link to the world. Dad improved steadily, and his death was a shock to everyone. Despite his continued significant challenges, the support the audiology provided Dad had a huge impact on his well-being during those weeks, and it gave him optimism. It also significantly contributed to his treatment plans, especially physio, who literally got him back onto his feet with aids. He had to respond to their directions, and he did because he could hear them. All of this is important to recovery of stroke patients. I'm no medic, but was told that it was best to try to stimulate him all the time to prevent his brain from switching off and forgetting things. We could not have done this without the support that enabled him to hear. My family and myself will be forever grateful to the audiology services who gave Dad back to us for a while. I don't think he died alone in his own headspace, a lonely stroke victim, but as an engaged adult who knew he was challenged but making progress. I think that's the first time I've managed to read it without crying. So.
Thank you, Deborah, for taking us through the story, and particularly drawing out the points from perspective of the differences that hearing aid has made to the last days of that gentleman's life and the care he has received. So it's really just open to conversation now from the board with regards to that story. Helen, if I pass back to you.
Helen, you're on mute.
Thank you very much. Apologies. I was just, thank you, Lynn. Thank you, Deborah. Comments, please.
Helen, I'd just like to say that that was an incredibly articulate and moving story, and it's interesting, isn't it, at how we can communicate that across the wards, because this won't be a typical problem.
Yes, I think that's a very good point. I also think it's possibly a more typical problem than we realise. I find it hard to recall any length of time I've spent in a ward. If I've ever been on a ward for more than half a day, I've always come across some patient who's got some issue with hearing aids or hearing or audiology or where they are or having them tuned, and it just really brings to life, doesn't it, the extent to which any individual's recovery is a team effort right across the hospital beyond the kind of immediate team. So as you say, Beverly, really important that we do share that learning. I didn't hear Deborah mention it, but in the version of the story we read, there was also reference to, on occasions, this gentleman's family finding his hearing aids in his bedding when they came to visit. And, you know, it was fine, they were able to put them back in. But there's also a lesson, isn't there, about for our own colleagues about the importance of hearing to everything else that's happening in that ward environment as part of that package of care. So making sure all of those elements are in place so that we really can not only give the best patient experience, but make sure that we've got the communication necessary to you know, fully implement the care plan. Jane, please.
I'd just like us just to think about it more broadly and think about what it says to us about seeing the whole patient and not just the diagnosis, because I think it's a really positive thing about making sure we have hearing covered and we make sure that people's hearing aids are being used. But I think there is a broader context to this, isn't it? And that is that we don't understand the lives and what's important to our patients, to all of our patients. And so we just need to take time to gather context and understand what's important to patients, what actually their individual needs are and what needs to be addressed. So for me, it's about seeing the person and not just the diagnosis.
Yes, yeah, absolutely. Thank you, Jane. A point well made. Sue.
Thank you, Helen. Yeah, just to echo both points really, as the daughter of a partially sighted and deaf lady, I realise how challenging that is and actually how frightening it can be if you can't hear properly, which I imagine if you're ill must be dreadful. So, and I pick up on Beverly's point, I just wanted to kind of ask the question really as to how we do capture that. So when I'm conscious, when I've been on the wards, we use some physical signage, don't we, for example, above beds, to make sure that staff can tell, for example, if a patient has dementia or whatever it might be. And I think there must be something similar that we can do, because as Jane said, it'd be very easy to not see the person and to perhaps confuse somebody as being, you know, confused and senile as opposed to just frightened and not able to hear. So I'd love to have an action captured about how we physically make that easy for people as you go around the world to spot that in the same way that we've used that before, because it is super important and clearly easy to forget. And just to say thank you for managing to get through the story without crying. I didn't get through hearing it without crying. So
thank you.
I know Angie wants to come in and presumably have a point to make, but I wonder, Angie, would you also perhaps reflect on the asks in respect of the two actions? One is how we take the history in such a way that we really understand the individual, and also how we might give some visual clues to that being a particular requirement when you've got the floor.
Thank you. And you've said what I was going to ask and say, so I won't expand on it, but just say thank you, Deborah. And we'll pick up with Lynn and Sarah about those very thoughts about how we share the learning and see the person as well as the practical things. So thank you.
Lovely, thank you.
So well done, Deborah, and thank you very much.
You're welcome. Thanks very much for having me.
And we'll capture those actions now as we conclude that item. So that takes us on, if we may please, to the Chief Exec's report.
Thanks, Helen. And again, just to reiterate Helen's comment earlier around how as a board we spent time last month looking at how we could be even better and a well-led board. And we focused on strategy last month. So just to guide people to the agenda, item 9, we will pick up the next steps around the strategy, and you'll see some of the discussions we had framed in the vision, mission, etc. that we'll talk about when we get to that item. Focusing on engagement, there are particular areas I thought I'd just draw out from my report. It's under R&R, but the COVID position and how we are working with all our teams to make sure that we do restore services safely. I got an email from a colleague this week to say, now that we've got no COVID patients, can we do X, Y and Z? And it just reminded me, as if we all need reminding, that this hasn't gone away, and that perception that we can just get on with things as normal is very far from reality. So as of today, we have 4 positive COVID patients in with us. And sadly, we have had 138 deaths to date from COVID, with 306 non-COVID patients. So just to give you a flavour of the hospital as we stand today, and some real excellent work happening around restoration. And one of the messages we said we would do at our board was celebrate and some of the positive work that we're doing and start as we mean to go on the agenda. And I just wanted to draw out the video consultations that I included in my report. So we've talked around outpatient consultations via telephone, but you'll see the 3 examples there of something slightly more than just an outpatient appointment, but some of those procedure type areas that I think is worth just celebrating. It may seem like small steps and small numbers, but the team are working really hard to make sure that they can support patients in a different way, and some really positive feedback from patients on those examples that you see there. As of today, we still haven't got the phase 3 letter that will be coming nationally that you'll recall we spoke about last time. I keep being told it'll be this week or next week. It was sometime in July. It's the 1st of August on Saturday, so we'll await and see what that looks like.
I think the expression you're looking for is it's in the post.
And we're not using technology in this digital world, because yes, it must be winging its way to us slowly. Not that there'll be any surprises, and not that it's anything we're not discussing, and I say the team's working on. Again, there's Tony can pick up any detailed questions, but I think it's fair to say diagnostics, particularly for our cancer patients, is the area that is challenging everyone nationally. I have to say, and obviously I'm biased, but Chesterfield are doing particularly well at restoring their services, and much better than some areas. So thank you to the team for that, but acknowledging there's a lot of work to do, and a lot of work not only to support our staff, but our patients in feeling safe coming back into hospital or to their GP. I'm just going to touch on risk assessments, and Jen will come in with the numbers for me in a second. It's important for us that every member of our staff has a risk assessment, and that is not just a form filling exercise, but it's a good conversation about how they've been, how they are, understanding the challenges that COVID has presented and how individual they are, and how much they change literally. I was going to say from day to day, but some days it feels like from hour to hour. We know also that particular groups are more vulnerable and at risk re-COVID. So we've been given the challenge to make sure that all our staff have those risk assessments, but our BAME staff have a risk assessment by Friday. So we've been working towards making sure that happens. And we got an update on the Midlands regional call yesterday that a number of trusts are at 100% of their BAME community having a risk assessment and mitigation actions being in place. And Jen, do you just want to give us where we're at with all our staff and then with our BAME staff so that board are up to date, please?
Yeah, that's fine. As at this morning, we had completed 69% of risk assessments for all staff, 90% of risk assessments for our BAME staff, and 84% for the staff who are in the at-risk category. So we're at 90% for BAME, which, as Angie says, is to be 100% by the end of the week.
Thanks, Jen. Happy to take questions on these in a moment. I'll just finish on a couple of other areas that I particularly wanted to highlight, and considering our focus on engagement later in the agenda. We had a good session with our mentors, and I know that'll be picked up in the patient and staff experience. And some of us did a virtual visit to ITU on a week ago on Friday, with myself being Canberra woman and Helen and Beverly joining me to walk around the unit. The staff there particularly appreciative that we'd joined them and listened to how their experience has been. And we managed to speak to a patient too. We know that there's challenges around how we continue to engage with all our staff and make sure they're supported across the board. And it was just another way of trying to introduce that I think worked well. You'll also notice that we're progressing with ESR. So again, board will be aware this is a long time coming in terms of implementing ESR, but just to flag that we have appointed some consultancy support to make sure that we get that implemented and can give all our staff the information that they need at a touch of a button. Last two things I wanted to flag as the system. Joined Up Care Derbyshire supported the progression of the shared care record business case, and a particular thank to Keith and to John Court and Lee and team who have all been supporting the system in getting that integrated care record that we will know will make such a difference to our patients and our population, but also to our staff. There's a long way to go, but I think it was a bit of a milestone to get that approval at Joined Up Care Derbyshire last week. And then the last area I just wanted to draw board's attention to was the latest data on freedom to speak up. Steady progress there, still more ambition we want to achieve in where we want to get to, but we're going in the right direction, and those areas that Abby and I and colleagues are focusing on pretty consistent, but just worth noting, I think, the progress that we are making in that area.
Thank you very much, Angie. Atul, please.
Thank you, Chair. Really pleased, Angie, to see those examples of the digital appointments and video consultations. Obviously, I think this is very much the way of the future, but I assume that the patients were happy and had a positive or more than positive experience of those, because that's obviously that's important to square that circle. We may think these are the way to do things, but are they happy?
Yeah, and I'll invite Tony, Lynn or Sarah to comment as well, but certainly the feedback I've heard was that they were very happy, not only from getting the care that they needed in a timely fashion, but the practicalities and the expense of not having to drive into the hospital, find a car parking space. So those things that are just as important for the patient as the clinical aspects of their care has been the positive feedback. The more, not less positive, I won't say negative, less positive, was the support for our clinical teams. So again, some of that technology in having to access different systems and how they were doing it is still a learning, and some of their frustrations are the areas that we're working on. I don't know whether Tony or Lynn or Sarah want to add anything to that. And Hal wants to come in as well.
I would come in, Angie. The feedback we're picking up has been really good. And just by way of example, I have personally experienced, if you like, a non-face-to-face conversation with a consultant within the trust from my own care. And the very things that we wanted them to do is making contact with the patient, i.e. me, missing me the first time because I wasn't there, but rang back. Really good conversation, follow up with some diagnostics. And my next appointment, which is in the 20th of August, has already been communicated to me by letter, and it will be a telephone conversation follow up again. So the system seems to be working really well, and that's by way of example of how all patients are being interacted with.
Thank you, Tony. Atul, please. No, sorry, I'm looking at Jane and saying Atul. Thank you, Atul. Jane, please.
Thank you.
You look nothing alike, by the way.
Thank you, Helen. I'd just like to ask about the section on supporting staff and the risk assessments, please, Angie. So really good progress. We're making really good progress. And I know that we've offered vitamin D to our BAME colleagues, but can you give us any feel for what other types of actions we're actually taking as a result of undertaking the risk assessments?
Again, I'm happy to kick off, and Jen or others may want to give examples and come in. So I reiterated that it is that conversation around how you are. So examples of making sure people are taking their holiday. So the drive to carry on coming in when actually we know that's not long-term sustainable, either physically or from a mental health perspective. So some robust conversations, I know, in some areas around making sure people are taking their leave, and we're supporting them in that way. You'll know that we've had Ashgate offering counselling for staff where they've asked for support if they've been particularly finding it difficult to work in an area that's been quite COVID heavy. That has gone down really well. Some of the feedback from staff is they don't necessarily want the plethora of health and wellbeing offers that we're giving, but they just want that one person to be able to talk to and have that counselling support. So that is there. Practical examples of risk assessments for home working so that we can support people who are working at home, and DSFS have done some good work getting agile working policies drafted for us so that we can use them to support staff working at home. So it varies because it is that individual conversation and making sure that we are supporting that individual. And we've been, I was going to say keen, we've been quite clear with all our colleagues that it is the line manager conversation. So yes, for some people that's been a heavy workload, but actually it's not about a HR conversation or someone else just checking you're okay. This is day to day, making sure our managers work with their teams to do that robust assessment as and when needed and repeated if needed. And for that reason, we've offered drop-in sessions for managers and staff where they said maybe they were struggling to do that as well as they wanted to. I can see Jen wants to come in, so I'll stop there. Things you want to add, Jen?
Yeah, just a couple of things. We've just around the sort of, I suppose, maybe back office staff, if that's the right phrase to use. I had a conversation with DSFS last week around the potential of, so we've got some screens in place for people who are in public areas, but in back office areas, if it comes out from the risk assessment conversation that people feel that would make them feel safer returning to work if the office layout can't work so that it's a safe 2 meters apart, or just if people don't feel safe, then there is an option for them to get some more practical support around screens in the office or different office layouts or working from home at different times to people that they share the office with. And then just on the health and wellbeing side of things, we've got some apps as well around supporting people with sort of mindfulness and mental health. And we are looking at our revised Westfield Health offer at the moment. It was put on hold due to COVID, and we're re-looking at that now with a slightly revised approach to how we roll that out.
Thank you, that's all really good to hear.
We've got a question from Atul about what's the feedback from BAME staff about the actions we're taking. I think it will be good to explore that a little. Would you like to comment, Angie?
Yeah, again, I'll kick off. Generally, good support for what we've done. So things like the vitamin D, there was a national debate about whether hospitals should be providing it. The feedback we've had is that staff appreciated that that message that gave. You'll have seen from my blog that a member of staff spoke out about how they felt being a BAME colleague in the organisation and what support they needed and maybe weren't getting. That had a mixed response from BAME and non-BAME community, but it's got the conversations going. And again, you'll probably have seen that we've done a survey of our BAME colleagues to say, did they want a specific BAME network? So we have our Be Yourself group, and that's been a way of our BAME colleagues being engaged and putting ideas forward in the organisation. But the question was, should it be separate to the Be Yourself group? And should they have their own dedicated one? And Sarah Turner-Saint will quote me on numbers, but I think it's 80% of those that that responded said yes, they would like a BAME network, and that was something that was started pre-COVID anyway. So that is being progressed with the support of the Be Yourself group.
Sarah, do you want to come in on this too?
It was just to add that one of the important factors that we added to risk assessments was to offer that from a colleague with a lived experience, if that was an option that was wanted.
Thank you. That's been helpful conversation about how it is we're supporting colleagues through this period of time. I'm conscious, Hal, that you offered to come in on the previous point, but I missed your offer. Would you still like to come in?
Well, it was just briefly to add to Tony that I think the general perception for people having virtual consultations is very positive about it. As always, there's the odd person where it doesn't work. I tried to carry out a telephone conversation a consultation with a deaf person the other day, and that was very challenging, and in a way that you can manage better face to face because you can use other aids. So we do need to be conscious it doesn't work for everyone. The bit I was going to mention was that the friends and family test feedback was put on pause for a period because of coronavirus. The friends and family feedback about outpatients at the moment is slightly more negative than it has been recently. That's probably partly around communication for people coming to clinics that weren't happening, because we've had an issue sometimes about getting that message out to them. But in a sort of wider and ongoing sense, the team, so Vicky Devlin and the team are trying to work out ways of restarting capturing that friends and family feedback. So as an ongoing thing, ATL will have information about what people really do think about virtual consultations, and then hopefully be able to act on any concerns or issues that are raised. So as well as the anecdotal, people think it's good, we're actually going to try and capture information systematically to assure us that it is working for our patients.
That's a really important point you make, Hal, and I know one that our non-executive colleagues are quite exercised about, and I feel sure we'll revisit in the context of the patient experience report, because we are of necessity transforming our approach to service delivery at the very same time when all the usual ways in which we collate information about patient experience are ramped down for reasons we understand. So I think, there's all the normal reasons for wanting to ramp that back up, but there's a very specific set of reasons about us really wanting to understand what this transformation in service delivery is meaning for how patients are interacting with us. So whilst it's really encouraging to have that kind of anecdotal feedback, I think we can't help but think the sooner we get not only the existing means of collating patient feedback, but perhaps even more modern means that go hand in hand with more modern service delivery, the better placed we will be as a trust. So I think there's a specific action for us to take away with respect to that. And I think the second action does relate very importantly to our BAME colleagues. Whilst it's very pleasing to hear about the progress that's been made on risk assessments, I think it will be important that the board are kept abreast of the actions that are taking place on the back of that, and indeed the progress that is being made in establishing a good dialogue with BAME colleagues. And I'm personally very anxious that we don't put any burden on BAME colleagues to address the issues that they might be experiencing working in the trust or living locally, because, you know, it is really incumbent on us as the leaders of the trust to be at the forefront of that, obviously informed by their insights and lived experience. And given we know that we're not seen as a particular area of good practice yet in this regard, I think the closer you can keep the board to all the actions that are planned and underway, that will be really good. So we'd like to take that as a second action in this regard, please. And as ever, Angie, your report has stimulated lots of really important discussion, which I think is almost always the kind of testament to how good a chief exec report is. So well done, not only on all your work, but in fielding issues here that are of real significance and materiality in terms of the board's deliberations. Thank you. So thank you for that. And that brings us on to the next agenda item, please, which is the board assurance framework. And as I trailed in my introductory remarks to this meeting, this is a really important item now, as it's also the opportunity for us to hear from committee chairs and through them to hear about the scrutiny and assurance that has been applied in respect of our integrated performance report and our risk registers. So I'm going to start, if I may please, with the Chair of the Finance and Performance Committee, Alison McKinnon.
Thank you, Helen. So my report back to the board is initially around some context and then some specific commentary around the risks that finance and performance look after. So the committee last met on the 8th of July. We had a very healthy conversation around financial arrangements at the moment and where they may or may not go in the future, and also around performance in different parts of the hospital, and how the regulatory oversight may be restored and the potential consequences of that. And of course, we had a detailed conversation both financially and performance on COVID and COVID response. So the letter that we've talked about that we're expecting to arrive in July, that hasn't yet arrived, is of some significance really for finance and performance, because we're expecting it to set out further restoration activity, which may or may not give us some more commentary on financial arrangements, and again on performance and regulatory oversight. So following that context, the risks that are actually articulated around finance and performance, the committee felt that it was time to refresh them in light of the strategic refresh. And so we haven't proposed any rescoring, but actually that we should take a step back and see what the finance and regulatory activity is going to be, and the refresh of our strategy, and then actually reword them, because some of the potential consequences of the more relaxed regulatory framework and oversight may well come back into being in the next few months, and that would change our perception of those risks and how we might score them. So no change in scoring at the moment, but an absolute desire to review the risks and their scoring in light of our strategy refresh, but also in light of changing environments around finance performance, finance oversight and performance oversight. I don't know if any of my F&P colleagues or Angie or Lee or Tony would like to come in with any comments, but that would be my summary.
Thank you very much, Alison. That's been very helpful. I'm going to move on, if I may, please, to Jeremy Wright, please, as Chair of the People Committee.
Okay, thanks very much, Helen. The People Committee met on the 8th of July, virtually, obviously, as we always do, under the consideration of the different BAF items. Under 4.1, we received reports from the Strategic Workforce Education and Training Group, including details about the workforce tracker and divisional plans for implementing those, report on the apprenticeship levy and the medical workforce plan, under which item we touched on the changes to the junior doctor rotations that have happened and are now being put back to normal. We took a report on essential training compliance, which I'm pleased to say is continuing to go up to 84%. And on also, we had a report on the human factors elements of the patient story, which we received here at the full board back in I think it was back in March. You'll recall it was the very sad case of a man who was admitted having had an ischemic leg, and there was a delay in transferring to Derby as a consequence, or during, it led to his demise. And we were asked, along with QAC, to consider what lessons should be learned from that. The outcome of that conversation at People Committee was that we had some assurance about human factors training and the way that that's now been incorporated both into training and into critical review of critical incidents. But we also had a proposal from Atul, and you may want to comment on this, that we ought to consider having an event once a year to commemorate such events and use that to reinforce human factors trainings. And the idea of a learning summit around this was floated, and I think Lynn said that that's something that we could perhaps consider. So as a consequence of all of those considerations, the People Committee recommended that the risk rating for BAF 4.1 should be reduced, with the likelihood of adverse consequence being reduced from 3 to 2, whilst the consequence remains at 4. So that would mean that the risk rating comes down from 12 to 8, and that's our recommendation to board. If I may just go on to the other BAF items, BAF 4.2, we received reports on staff engagement, on flexible working, on health and well-being, and on the just culture concept, and we don't recommend any change in the risk rating for 4.2. Under 4.3, we received reports on people strategy success measures and leading the Chesterfield way, and again we don't recommend any change in the risk rating for that. So that's in terms of the risk ratings. In terms of any other business, we had a brief discussion about Black Lives Matter, and we've already touched on the way in which BAME staff are being supported within the hospital today. And we also said farewell to Ian Ciara, who's been covering for Jen in her maternity leave, and welcome Jen back, and it's really nice to have Jen back at the board again today. So that's it as far as the PC meeting on the 8th of July is concerned. The other thing just to highlight in terms of the IPR, you'll see in the IPR later in the consent items, amongst the people, the workforce element of that, the one thing to particularly take note on is the high level of nursing vacancy in the Band 5 nursing vacancy. This we did touch on briefly at PC, and it is, of course, explained by the fact that we have increased the establishment of Band 5 nursing places, but we haven't yet been able to fill those establishment places, and the consequence of that, of course, is that the vacancy rate is up, but it's coming down. So I'll leave it at that. It may be that other NED colleagues from PC may want to contribute, otherwise, obviously open to questions.
Thank you very much, Jeremy. I'm going to go directly now, if I may, please, to the Chair of the Quality Committee, Jane Stringfellow.
Thank you, Helen. If I can tackle this in terms of items that we discussed at QAC and then come back to the BAF, that would be really helpful. So there's nothing that we wish to escalate to board, but I thought it was really important just to run through just a couple of the items particularly that we've discussed and we've focused on. So one of the things is clearly the CQC Action Plan. So I know that that was as a consent item later in the agenda, but I just wanted to give board full assurance that we have reviewed both of the must-do items that arose from the CQC inspection and reviewed the action plan that's gone back to CQC and noted the time frame for completion of 3 months. We also heard that all of the should-do items are being addressed through the various care units and will have oversight through Fundamental Standards Group and Quality Delivery Group, but we look forward to seeing further information on those actions in future. From the IPR specifically, there were a couple of items around pressure ulcers and falls, and there had been a query about statistics, and we noted that some of the changes are a result of the patient mix as a result of COVID. We also continue to focus on mortality, particularly crude mortality, looking at the impact of COVID, but also making sure that we're really clear that those statistics are not masking any other changes in terms of mortality for our patients. So we looked again at the mortality outlier report on congestive cardiac failure and noted that we intend to bring forward a care bundle on that. So I think those were really quite important issues. Mortality continues to be a focus for the committee. In terms of the BAF, I'm certainly on, if I go to 1.2 and 1.3, we didn't propose any changes as a result of our discussions on the 13th of July. BAF Risk 2.1 had been allocated to Quality Assurance Committee, but we noted that Angie preferred now that this sit back with the board, so I know that you've already teed up how to make a comment on that risk specifically. So I want to take us back to 1.1, which is patient experience, basically about patient experience. Our recommendation on this is actually that the likelihood score should be reduced from 5 to 4, given an overall risk rating of 12. Now, given we've discussed some of the limitations on FFT, family and friends test at the moment, you might think that that might be a strange ask at this time. But I think board will recall that we actually raised this risk last summer to 15 on the back of the issues around, specifically around ED. And actually we've noted really significant progress on ED, and we think that now, given that that was the sole reason for raising it, we should give consideration to lowering that risk down. Again, we tested out what other mechanisms were in place for capturing patient experience, so thinking about complaints processors, social media, etc., and noted that actually the trust is receiving really positive comments about the quality of compassionate care. So I will ask other colleagues if they want to make any further comment in respect of 1.1, but we would ask board to take consideration of that recommendation.
Helen, you're on mute.
Apologies, just saying thank you to Jane, and good to learn of the continued focus on mortality and indeed clinical effectiveness. And to conclude the reports, I'm going to go next to Mike Killick, please, as chair of both the ARAC and also of the DFSF's Oversight Committee.
Thanks, Helen. We'll take the DSFS Oversight Committee first. We met on the 20th of July. We had Zoe and John Court from the exec team to challenge and query what was going on in the subsidiary. It's finding its level now. This is the third or fourth Oversight Committee meeting we've had. We missed one because of COVID. We covered 4 key areas, really. We looked at some risks, and I'll come back to those in a second. We looked at a finance update, which was there or thereabouts. Dennis took us through the staff survey, which he's got another spot on the agenda later on today. And we also signed off his views on the subsidiary strategy, which dovetails nicely into the board's current strategy, and those slides are attached to the minutes. if we look back at the risk that we discussed, there was one new one which was brought on by Ian Hazel, which was the recovery and restoration issues that the business is facing. As Angie's touched on, we've had to do quite a lot of risk assessments in that area, and that's clearly a new risk which we need to add into the framework of risks in the hospital. But we felt that most of the issues that were being addressed were being handled sensibly, and certainly the feedback from John Court was pretty positive. We also looked at 3 existing risks. One was around Microsoft Office, lacks an insurance agreement, but that's been pretty much covered by the new introduction of Microsoft Teams and the MS365 licensing, which NHS has now been offering. We looked at the potential for cyber attack, and that's always going to be there, but we continue to believe that the defence mechanisms we have in place are pretty sophisticated at this point in time. The one which was slightly more worrying, but I think we got to a sensible conclusion in the end, again with some input from John, was around whether we have insufficient oxygen support to meet the level of demand. And Chris Tan gave a quick explanation of where we were, and that we now have a full plan and strategy to make sure that we have sufficient oxygen for the beds that we need, and that all seems to be under control. So it was a good meeting. It missed Tony and or Angie from holiday, but as I said, we had Zoe and John from the exec team. Obviously Lee was there wearing 2 hats, and it's finding its level, and I think that Dennis and the team are doing a good job. There was a lot of complimentary comments from the exec team about the support that DSFS has given through these very difficult times. Clearly there's still challenges around getting people back to work and social distancing and a few issues like that, but the business is the subsidiary business is coping well. There was one slight kind of issue we had to chase to ground, which was clearly we've had to park some of the more third-party commercial income driving opportunities which were enshrined in the creation of the DSFS business case, partly because of COVID, partly because of short of cash, partly because people have just been busy. I just wanted to make sure that the guys in DSFS didn't take that as a change in policy, which it absolutely isn't, but was just a parked for the time being. And that, I spoke to the guys individually, and I think everybody in that part of the area accepts that now isn't the time to start running around trying to drive third-party business when we have other priorities. So that landed well, and it was a good debate which we ran to ground to make sure everybody was satisfied. So I'll park there before I quickly go on to the ARC, unless there's any particular questions on DSFS.
Thank you, Mike. We might just go straight through to ARC, if we may, please.
Okay, well, we met on the 19th of June, primarily to sign off all of the statutory business that the Trust has to file with the various authorities. And if I can just pull up the relevant page, I'll tell you exactly what we signed off. We signed off, excuse me, PC problems. We signed off the Chairman and Chief Executive Statement. We signed off the Performance Report. We signed off the Remuneration Report, the Accountability Report, and the Statement of the Chief Executive's Responsibilities. They were all approved by ARC for subsequent signing by the relevant authorities. And we approved a slightly truncated set of financial accounts for the Trust, given that there were no quality accounts required this time, again, due to the COVID situation. But all the numbers were signed off. We had a clean bill of health from our external auditors, KPMG, and it was I won't say it was a rubber stamping meeting, there was some debate, but primarily on the 19th, all of the documents that are required by statute to be signed off were duly signed off or approved by the board for subsequent authority. And that was pretty much it for the ARC this time round.
Thanks very much, Mike. That's really helpful. I'm now going to open it, if I may, to board colleagues if they've any questions, queries, thoughts or observations following those reports from our 5 assurance committees.
I just wanted to echo what Jane had said with regards to the risk assessment changes and to support that recommendation to board.
Thank you, Lynn. Angie?
Just picking up on Alison's comment earlier, I note the increasing emphasis on managing not only the finance but performance across via the system. There's a letter come out yesterday around regional boards that are being managed through system representatives rather than organisational ones, and a presentation we heard yesterday, a bit of a challenge around how we'll manage validation of waiting lists as organisations, potentially saying, not that you can't, but it will be really difficult, A, given the size, but also that conversation that our patients and our clinicians need to have across primary and secondary care. So I think it'll be interesting and would support Alison in that little bit of a step back over the next few weeks as we pick up how we're going to manage and performance and get that assurance from within the organisation, but as part of that system.
Thank you, Angie. Atul.
Thanks, Chair. I wanted to make 2 points. I mean, firstly, on Jeremy's feedback and the idea of a kind of a learning commemorative session. The thing about cases that are difficult is we learn a lot when they happen, but, you know, human nature being such, memories fade, people change. And I think it's important to have the opportunity to refresh those kinds of lessons as we go. And that kind of refreshment really to underline that we want to be outstanding in CQC and provide that evidence of an ongoing embedded learning, if you like. And the second point I'd like to make is just to echo what Mike said about DSFS. I was an observer for the Oversight Committee this time round, and just like to echo all the work that DSFS have done to support us and the hospital and staff and people through this. But also they're working obviously on their strategy, forward strategy, and that will be something really interesting to look at when it's in good shape.
Thank you, Atul. Hal, I wonder if I might invite you to come in, perhaps to speak a little bit more to BAF Risk 2.1 on the basis that, you know, whilst Jane has described certain elements of it, it's probably the aspect of the BAF that continues to be read that is less immediately explainable by current COVID circumstances or issues of filthy lucre. So just to have a bit of a personal perspective from you around some of that would be very helpful.
So I'm not, I suppose I'm not quite sure what the ask is here. So the 2.1 is the delivery of the portfolio of sustainable high quality services to the population the trust serves. Is that correct?
That's right. So
which sort of aspect is it that we're wanting clarity on from that? It's obviously, you know, a core bit of what the trust does is providing high quality clinical services in all respects. And I suppose from the population point of view, it encompasses both the hospital and rural primary care in a way that it doesn't involve many secondary care hospitals. But what was the query about it, in the sense that is it big in the sense of what's different with coronavirus, or what's
no, it's not that actually, Hal. The issue is much more about the fact that we've had COVID. We've now got focus on restoration and recovery, potentially restoration and recovery and in anticipation of a second wave of COVID. With a determination to learn lessons from the changes to clinical practice that have served us well during COVID that we want to take forward into the future, yeah? But there is a risk now, isn't there? That in the race to re-establish services as we knew and loved them, albeit building in learnings and lessons from COVID, we missed the opportunity to do the less strategic thing, which was always the intention of this BAF risk, which is the kind of strategic review and, to any extent necessary, redesign of services, not least of all in the context of good system working. So there is a risk to that lofty goal in some of the current context.
There is a risk with that, and from my perspective, an awful lot of that risk comes from the Derbyshire system wanting to implement its kind of excessive governance arrangements about how we do things and wanting to be forever putting checks on things. If I give you an example of how we are really truly trying to transform the way we work, we talked about outpatients earlier, and we talked about virtual consultations. And one of the things that we've done during COVID is that we have, so I've just realised my video was off, so apologies for that. One of the things that we've done during COVID is when we've had referrals from GPs, we have done a clinical triage effectively. So we've both been looking at who really needs to be seen in hospital, who can be managed in different ways. And the existing national platform for GP referrals is something called ERS, or commonly known as Choose and Book. And what happens there is the GP sees the patient, they decide they need something doing in the hospital, and an appointment in outpatients is automatically generated from that point. Now, that's a very kind of inflexible system in lots of ways, because for many patients, an outpatient appointment might not be the right thing, not just in the context of coronavirus as to whether a face-to-face appointment is right, as opposed to a virtual appointment, but also from the point of view of whether it might be more beneficial for the patient and for system costs to say, well, this patient should have diagnostic test first, or it might just be that we need to give advice to the GP rather than the default position being that the patient comes to an outpatient clinic appointment. So we've agreed with, we have a primary secondary care clinical transformation group, which is very kind of, the CCG is aware of it, but it's very governance light, and we've just had lots of good conversations with primary care colleagues about how we can best manage this going forwards. And with the help of Maria and with Claire Carson, from the 1st of September, we're turning off the ERS Choose and Book system completely, and that's been done in consultation and with the agreement of GP colleagues. So what will happen is the GP will refer a patient to the hospital for further consideration, if you'd like, rather than automatically an outpatient appointment. And that the consultant will then take that referral letter and will decide what's the next best step. Now, for some people, that might be a clinic consultation, either virtual or face-to-face, but for many people, it might be straight to a diagnostic test. So as a gastroenterologist myself, I might decide, well, someone just needs to go directly to an endoscopy, because that's going to be needed based on their symptoms, and there's no point in us seeing them in clinic first. Or they might need to have an x-ray examination, or they might need to see a different specialist, so they might need to see a dietitian. Or it might just be a question of I'd be saying to the GP, well, actually, we don't need to do anything about this at the moment. You need to keep monitoring their U's and E's because they've got a degree of kidney failure, and at the point it comes to this point, we do something differently. So that's an example of how we're trying, and I think that system will be better for the patient and will be better for the system. It strikes me as a more effective, more efficient system, both for patient and for the system. And I think that's an example of how we are trying to keep an eye on the bigger strategic picture. We're not just trying to go back to how we did it before. That's an example about outpatients. I could tell you a different example about how we're doing pre-op theatre assessment. And I think it is just to say that we really truly are trying to change the way we work. And that is all happening. It's not, we've not just said, right, well, back to how it was before.
Thank you very much, Hal. Those examples are very helpful illustrations of the opportunities and challenges that you're now facing. Did you want to come in on this, Angie?
I think we'll pick it up under the strategy refresh item later, and that was my comment around, if we look separately at clinical service strategy, it's a bit like the digital comment to a digital strategy. What are we actually doing? So for me, it's about where's the risk for our population in the services that we provide, and how do we mitigate that risk through some of the examples that Hal's described, or by working across the system very differently, which we know we're going to be driven to do. So the work that we're doing around the strategy refresh is getting all of our teams to think about what does that mean for their services. And I think it's a real challenge for us as a board to then come back and say, so what does that mean for us providing care for our population, and how do we balance those risks of being in some of these services or maybe not, which we don't tend to be very good at discussing in the NHS. But that's certainly what I want to see us do over the next few weeks as we do that strategy refresh and bring it back through board.
That's very encouraging. Thank you very much, Angie. Well, I make no apologies for giving the amount of time we have to that item. Obviously, we've covered some really important ground. Just before I attempt to summarise, can I check if there's anybody who wants to come in with any final comments or remarks?
Helen, it's Tony.
Tony, and then I come to Jeremy.
Okay. Yeah, I would just support your initial challenge and Hal's response within the system space and across the organisation. Yes, there's a risk people might want to drift back, but we're really challenging. If anything, the conversation I've been having in planned care just prior to board is to be even more radical than we have been during the COVID period as a means to restore and recover. And so those conversations are taking place right across the system with an appetite to do things very differently. And the comment, Hal, we're all worried about if everybody goes too heavy on the governance, because we've been really quite nimble and agile during the COVID period. So again, we're trying to resist putting heavy governance in place that slows things down, but appropriate governance so that, you know, we have the right oversight. So I just wanted to stress that point.
Thank you very much, Tony. Jeremy.
I think we can cover it in your summary, Helen, but I just wanted to make sure that we're clear for the minutes whether or not the board agrees the recommendation from People Committee that the risk rating on 4.1 is reduced.
I shall come to that in a moment, Jeremy. Yeah. Anybody for anything else?
Just to note, the working group that we have set up is meeting on Monday, and that's just to look at the presentation of the BAF and how we can strengthen that
and align it with our emerging strategy.
Yeah,
very good, very good. Okay, now we've had a number of recommendations from the committee chairs, including in respect of the BAF risk about having the right people with the right skills in the right place, that risk being reduced. From QAC in respect to patient experience risk being reduced as described, and of course the important assurance we've had from ARAC about the scrutiny of the assurance committees and that process is working well. So with those particular points and indeed all of the recommendations of the committee chairs, can I ask if we are content to agree them?
Yes, happy.
Yeah, thank you very much.
Yes.
In addition to those recommendations, we will also, of course, take away the action that was discussed at People Committee to consider further whether our desire to be a learning organisation will be helpfully supported by a commemorative event annually for incidents and the learnings that have been discovered as a result of that. So we'll take that specific action away in addition to approving the recommendations.
Helen, would it just be worth linking that action to the action around Callum Hubbard, which is where we said a couple of board meetings ago that we would do some sort of commemorative action to the board members will remember that case, but in some ways they're quite linked issues, aren't they? And I wonder if it would be worth joining those two together.
I think that's a very good idea, not least of all given the advocacy we've had from Callum Hubbard's now deceased father about the importance of learning. I'm sure it will give the family great comfort to know that you know, what happened to their son very tragically had not only improved practice in that area but across all areas. So I think that's a lovely suggestion Al, and we should look into that. Thank you. Now I'm going to move us on. We come to next 3 items on engagement, but before we take them, I notice on the chat that Joe Lacey has joined us. Welcome, Joe.
Thank you.
Joe, I imagine with the pressures currently on primary care, it might suit you quite well if we were to move along to item 10 and take that now, so that you have the choice of being released back onto your morning.
That would be marvellous, thank you.
Yes, so let's do that. So we're going to go now directly, please, to item 10, Royal Primary Care Developing the Strategy. And we will then go back to the earlier items on the agenda. So I would say to you that you can have every assurance, Joe, that the paper has been read. But the paper, as you'll be aware, is, let's say, describe it as an outline. And there are a number of comments I know that board members want to make. And as I said to colleagues just before we started the meeting, please, Joe, don't feel that you need to play ping pong with us in a Q&A session. We're not here today looking for answers about the strategy for Royal Primary Care. The purpose of this item is that it was intended to be in a scoping paper for to get proper commissioning by the board of what it is we need to see next back at board by way of a strategy for Royal Primary Care. Yep. So from our perspective, a good conversation today looks like having flushed out all the big thorny questions, not necessarily having begun to answer them. So I hope that's helpful by way of introduction, and if there's anything else you'd like to add yourself by way of introduction, please feel free to do so. And indeed to you, Tony, that invitation's extended.
That's perfect, Helen. Thank you very much for that. And I think it is very much an outline. I think our strategy was refreshed 3 years ago, and we have succeeded very well with our strategy, but I think the national picture has changed significantly that we need to consider, but also it's at the right time, CRH reviewing its own strategy, and also in light of what's been happening with COVID, what we might have thought was appropriate 6 months ago may not be appropriate going forward. And so it really was a conversation to try to join up all of those things so I can have an idea of how we want to take forward Royal Primary Care, knowing what the board's thoughts are.
Thanks, Joe. Obviously, Keith takes the lead for us from a NED perspective on primary care. So I'm going to go to Keith in the first instance, please.
Thank you, Helen. Hi, Joe. Hi. Sorry, apologies for my enormous cold today. It makes me, I feel like I sound terrible. Sorry. So a conversation yesterday as non-exec prior to the board, and I think it was about trying to, I know today was about trying to get to some of the kind of, as Helen described it, I think the thorny issues, if that makes sense, and really understand how we can then address that and bring that back to the board in September. So I think some of the things we talked about yesterday were around the whole piece around how RPC feels like it's more joined into the hospital. I think some of our comments was around it feels very standalone at times and very separate, and we need to find a way of making sure that join is more seamless, if you like, and how that reports into the hospital and how it works in the hospital, so that we don't feel that it's Chesterfield Royal and Royal Primary Care, appreciating that the two things are clearly have differences in the way they deliver care, but how we get that to a more joined piece effectively, so it feels more seamless, I think was one of the areas that came up. And in terms of the strategy, I think there were 3 big things that came out of yesterday. One was around population health and the kind of equalities and how we manage those conundrums and the questions that drives for us in relation to the patients that we look after, how RPC grows, and what does that growth look like. And I know that was a conversation that I and Tony had in quite some depth when we spoke a few weeks ago as to what that strategy looks like. And I think also back to certainly as a non-exec and from my responsibility with the governors, tied to how does that, interaction of kind of care from primary care to secondary care, and also potentially secondary care to primary care. So are the services that we could provide in RPC that we currently provide in the hospital, is there a movement there, and vice versa? How do we look at what rural primary care refers into Chesterfield and understand how we can get some of the gains and the benefits in the system, so that we can then potentially deploy that across primary care beyond. So I think they were some of the debates that we had. I'd be very happy if any of my colleagues want to chip in and add stuff that I've missed. It was a lively debate, but a positive debate. And I think it's about how we answer those. And to Helen's point, I don't think today's about answering them. September's about answering them. But does anybody, is there anything I've missed, Helen? I appreciate that it was quite a lengthy conversation yesterday. I don't want to feel like under it.
No, not at all. I think you've done a great justice, and I hope, Joe, the fact that we were willing to devote some time preparing properly for this discussion tells you about the importance we attach to it. So as Keith says, there are definitely 3 elements to our concern. The first element is about performance. We feel that we're not adequately cited on performance, and despite the fact we said it reports like any other division, it doesn't feel like that. And we feel we have a range of very important accountabilities that we're not currently able to discharge effectively. So that's a concern. There's issues about capability. Is there the right capability in RPC? Capability and capacity, really. And there's issues about who's in charge and who do we turn to, and how do we get not only good reporting, but that understanding of the accountabilities that sit alongside that reporting. Not that we want to micromanage RPC, we don't, but we do need an assurance framework that's as strong as our assurance framework for any other part of the hospital. That doesn't mean the same, because obviously it needs to be proportionate to the scale of the operation, but it does need to be as strong and as effective. And as Keith said around the strategy, I mean, the idea of this paper was to tell us what areas the strategy is going to cover. It doesn't, that's fine, the next one needs to. But I think it's only fair to put you on notice, Joe, if any strategy comes back to this board that doesn't include some population health targets, that doesn't talk about growth in the context of the hospital's desire to tackle health inequalities, and if it doesn't describe kind of in words of one syllable, which services may transfer out of secondary care into a primary care setting and or be delivered in a primary care setting, we probably won't like it. So I don't think you can say fairer than that in terms of you having been put on notice of what's required. But I think, insofar as we've got time to extend this conversation now, I really would encourage colleagues to put anything else on the table now that is going to be a disappointment to us if it's not fully covered on the next outing here. Atul next, please.
You're on mute, Atul.
Thank you. Thank you. Just to echo some of what's been said, Joe, I mean, I would encourage you to be bold. When I first came, this all happened when I first joined the board, and I thought, what a brilliant idea to have primary care, secondary care as part of one organic whole. And I'm still waiting to see the benefits, the real benefits for patients and for us for that. Obviously, it takes time to settle in and so on, so I'm not criticizing, but I think now is an opportunity for you to be bold and sort of, what's in it for the patient? How can we make things easier, simpler? And on the public health point, an example from Leicester, where I live, because of the COVID situation, one GP's practice held a webinar about the whole situation. 5,000 people joined. There were over 2,000 questions that were answered. Now, this is a GP's practice actively engaging in public health issues. And there may well be other things about health inequalities, about messaging that we generally need to give to the population, in which I think our front door of the RPC would be a real benefit. And I think if all of that can be put together in the way sort of Keith and Helen suggest, that would be really great.
Thank you, Atul. Sue next, please.
Thanks, Helen. Yeah, thank you, Joe. I'm really looking forward to seeing this coming back in September. Just one thing really, which has been referenced already by colleagues, but to really emphasise the patient at the heart of all of this. We have talked about this at board, that it has to be completely front and centre of everything we do, of our strategy refresh. And I know it's stating the obvious, but sometimes the obvious is worth stating. So I'd just be keen to make sure that that's very clear, and we are talking about patient pathway opportunities as opposed to seeing them as distinct parts of the system. That was it from me, but thank you. Good luck with it.
Thank you.
Thank you. Beverly, please.
Thank you, Helen. Just obviously recognising there's some work being done in our RPC delivery of services with the patients at the core, but we really need to see a sustainable financial model. And I wonder if we've really looked at what is the optimum critical mass for RPC. When we first chose to take on the practices, it was on the understanding that we would at the very least break even, but probably make a profit, and we have yet to do that. So I really wonder whether we're even at the right size, but I'm sure that will be embraced in the final report, Joe.
Okay.
Thank you, Beverly. Lee, please.
Thanks, Helen. I'm just going to tease out the comment I've made in the chat box, really, just about, it's the same comment I make about the hospital strategy, really, and the need to have a sort of galvanising set of principles for the organisation. It's probably quite equivalent for RPC, just about how is that positioned more broadly in the emergent sort of integrated care partnership space and its requisite PCNs. There's a slight risk about us ploughing our own primary care furrow in advance of September and not quite having the engagement with the broader hinterland of general practice we've got referring to the hospital in terms of our integrated care goals. I'm not saying stop, but I just think we need to be very mindful of that tension.
Thank you, Lee. And that was something that I was going to just sort of mention, that whilst Royal Primary Care is absolutely keen on looking at some of those integrated care pathways, we are part of the PCN, and it's really about how can we do this piece of work, ensuring that we've got those good links, obviously with CRH, but also ensuring that this works equally for the PCN. You know, we have to be part of the wider system, and we would like to do that amicably.
Of course, thank you, Joe. And we've got a helpful comment also from Lynn on the chat about the strategy obviously needs to consider enablers primary amongst those workforce, which I'm sure you will be on with. A number of us were on a national call yesterday, Joe, and there was a lovely quote from that national call, which was, if you don't have a digital strategy, you don't have an organisational one either. So we'd also leave you with that bit of wisdom. Yeah, very good. And some endorsement from Hal there about the importance of working within the PCN and indeed the wider system. So I think that's all really important. Now, I think the other bit of advice to the wise we'd give, Joe, is obviously it'd be really good if you took counsel from Keith as you develop the strategy. And it'll obviously be a great help to us as a board if Keith can be supporting the strategy when it comes to board. It won't be helpful to you or to any of us really if he's catching up with it at the same time as the rest of us. So please do bring him into the development of that, and feel free to draw on any of us, I would say, in the run up between now and coming back to board. So I think the last question is for me to Angie, please, in terms of when can we expect to see the strategy back at board, please?
We're aiming for September.
Aiming for September.
Yeah, so next board meeting, because we haven't got a meeting in August.
Very good. So we look forward to seeing you again in September, Joe, and please do call on us as you need between now and then.
Lovely. Thank you all very much for your support. And I do think there are going to be some tensions with some of the things that you've sort of highlighted to me that I may need to have further discussions with the execs just to see how we can direct them in the right way. So thank you.
Thank you. Thank you, Joe.
Bye.
Bye-bye. So it was good to take that item then, but that means we need now please to go back to the first of our 3 engagement items, which is on the patient and staff experience report. I come to you, Lynn, but in the context that be assured board members have read the papers.
Thank you, Helen. And that's really the introduction, which is the paper provides the content with regards to our priorities for the quality strategy, and also within the appendix it brings out the latest CQC inpatients national survey, which, as you can see, was done back in July, so it's slightly out of date, but nonetheless the results are there for your information and the actions taken that we've identified so far. I think the other main thing to pull out for the board for further discussion, apart from the CQC's inpatient survey, is with respect to the engagement that the executive sponsors have had within and across the organisation, of which I'd invite my colleagues to comment anything that they wish to participate within that, and also the mentor programme as well. And I think that's quite a key thing to bring up, because it's very new, and I wasn't at the launch myself given the time leaving, but colleagues were, and I think it went down very well with regards to the mentorship programme. So that's open for comments and questions from the board. Thank you.
Thank you very much, Lynn. I know both Jane and Sue want to come in on this item. I might go to Jane in the first instance, please.
So we had some conversation yesterday about FFT and also the use of SMS to collect information. So in terms of the text messaging services, we were interested to know about whether there are barriers to the wider rollout of that in the absence of other systems available to us to get our patient feedback. So that was a question really about sort of generally about how we are currently collecting our patient feedback. But also something we've touched on earlier, which is that we have said through some of the mechanisms we already have, we do know that things have been fairly positively received by patients. We spoke earlier about outpatients and whether that is about the cancellation of appointments where there's been some negativity in terms of friends and family test. But actually, what are we doing more broadly to understand the changes that have been made in terms of service changes for patients? So if we take outpatients, so how are we measuring the fact that we do or do not think that our patients think that this is an acceptable way of carrying on our services? And secondly, how do we know that the outcomes for our patients are as good as they would have been if we had been operating in the old manner? Now, that's not to say that I think that we shouldn't be moving forward. I absolutely do. But I do think we're making some radical service changes, and it is beholden on us to understand the patient's experience of that. So what is their felt perspective? What is their felt experience? So how do we know all of that? So a bit of a ramble, but in essence, what are the barriers to us moving forward with SMS across other services, other areas where we're collecting feedback? And secondly, how are we understanding our patients' understanding of experience of the services, and how are we understanding the outcomes?
Thank you, Jane. Lynn, would you just hold on to those comments for a moment, and I'm going to go to Sue, and then you can come back in the round if you would.
Thank you, Helen. Yes, hi, Lynn. I think just to pick up on Jane's very early point there about the SMS thing. I know that there's a lot been going on, and we've been kind of been pausing the friends and family stuff, but I'd be really keen for us to, if we can, help unblock any barriers to us just really kind of ramping that up. I think in my kind of recent experience of doing lots of stuff from home, I'm constantly seeing digital ways of getting my feedback, which are super easy to use, and then I know at the receiving end are super easy to collate. So I'd love us to just kind of ramp that up in that whole digital way. It looks like a great opportunity for us. I know it's not new news, Lynn, but I'd just like us to explore accelerating that. And then the other bit, which is entirely unrelated to that, is about how we might join the dots a bit between the Black Lives Matter activity right now and how we link that in for patients, but also as well as for staff. And I know it's really early days, I'm not expecting you to answer that, but I just wanted to kind of register that as something that I'd like us to see pulling out. And even whether we might want to have a look at our staff mentor partnership in that light as well, where there's some reverse mentoring that allows us to put colleagues in the shoes, you know, other colleagues from a Black Lives Matter perspective. I just say that because I've just started doing that where I'm in my other job, which is proving to be really helpful. So yeah, I'd like us to see that pulled out for the staff experience as well and patient experience if we can. That's me. Thank you.
Thank you very much. Lynn, could I ask you to come back on those comments, please?
Thank you. This is a developing report, as you'll note, joining myself and Zoe into the same report. So I appreciate the feedback that we've had today, and Jen and Sarah will probably take some of those comments back. But to take the points specifically, with regards to SMS, I absolutely agree about accelerating the requirement to take that forward, particularly in areas that we've not used it before. And that was mainly as a result of the contract that we previously had, the capacity within the team. And that is one of the things that the team are now exploring, taking forward for all areas, not just where we've done it previously. So I don't think there are any particular barriers, and but I don't have the detailed answer to that, but I don't think there are particular barriers. It was more about what we were doing at the time and now wanting to expand on that. So I will take that point forward about accelerating it. Thank you. With regards to outpatients, Tony may also, our Sarah may want to come in on that specifically, but we are looking at how we're getting the feedback, and the responses on what they're telling us is absolutely the important aspect, not the volume of responses, but actually what our patients involved. And certainly through our outpatient board and the transformation that's happening there, that is very key, and Vicky is linking in to make sure that we are getting that. And we're trying to pull that out through the SMS text messaging service that we do have. But this response is following, so you're absolutely right. In terms of clinical outcomes, we pick that up in a different way, but in terms of their experience reported outcomes, we definitely want to know we're getting the messages that they are telling us. And I think there's more work we need to do, either on a face-to-face deep dive basis, so we're in there getting that feedback as that transformation is happening, or through our general SMS texting. So Sarah, I'm sure, will take that forward with the team moving beyond today. With regards to the Black Matters, that point I think may Jen want to come in on, and is an area that we need to explore further, and how the relationship connects, as you've asked, Sue. I don't know if Jen's got any more that she wants to say on that.
I was just going to say, Sue, that we had been looking at reverse mentoring with BME or BAME colleagues in the past, and we'd spent a bit of time talking to Derbyshire Healthcare and Derbyshire Community Healthcare Services who already have that in place. So it's something that we hadn't really progressed because there wasn't a huge amount of interest, but I'm wondering now with the Be Yourself group and the expressions of interest that we've had in setting up a BAME network group, that we might be able to now make some more progress on that. So it's definitely something that we're looking into.
I think, Jen, it's really important, though, that we expand our understanding of the BAME requirements beyond our staff. You know, any organisation needs to see the BAME implications of staff as really of primary importance, but also the BAME implications of our patients and service users. Because I think if we don't see that in the round and understand what the particular requirements of both of those key stakeholders are, we're only ever going to do half a job.
Yeah.
And we've got a drive and a focus on BAME through kind of some of the staff initiatives, but it's really important that in respect of patients, we don't just see that in respect of our staff, but we're also seeing it very much from the patient demographic. And I appreciate that may not fall as neatly into your portfolio, but I think as an exec team, we'd really encourage you to kind of work across the whole spectrum.
We have Vicky Devlin on our Be Yourself group to make sure that we link in with the patient side as well as staff, so that we consider the whole. So that is definitely something that we'll talk through with Vicky and her team as well.
Very good, thank you. Do we have a team wanting?
If I could just add into that as well, in terms of the COVID element, we do take the BAME elements into consideration when looking at the appointments and where they might want to come in at the start or end of the day, for example. but there's also the other protective characteristics that I think all comes into the round in terms of patient experience that we need to consider.
Absolutely. Yeah, well put. Thank you very much, Lynn. Lee, did you want to come in on this? Or maybe your hand was just up from a previous time. Okay, that's fine. Are we happy to note the patient experience report and in particular the action around extending SMS to all patient pathways and broadening the definition of our focus on BAME beyond just our staff colleagues into our patients that may be BAME or indeed have particular requirements due to any of the 8 protected characteristics? Very good, thank you very much. And I'm going to move us on now, please, if I may, to the DSFS staff survey. Warm welcome to Dennis, who I believe is on the call with us.
I am.
Are you going to introduce this item, Dennis? As I say, you can do so briefly. We have both had the opportunity to consider your report and have some discussion of it.
Yeah, no, that's no problem. Thank you, Helen. Good morning, everybody. I'm really pleased that I am able to talk about the DSFS staff survey. It was the first one for us, of course, and quite important in the context of establishing the WOS, because there was some concern and apprehension around staff engagement, people going away from the NHS into a subsidiary. So this was a very important piece of work that we engaged with. What I would like to draw out are 2 things really. The first is the key findings. Two elements on that is the response rate has been very high. So we are pleased with that. That means that people are still interested and feel that they can speak out and that their opinion matters. And secondly, the sort of no significant shift in the outcomes compared to the staff survey done by the Trust the previous year. Because of the apprehension about staff engagement, I think it's an important milestone and a good foundation to build on to not go backwards in staff engagement and satisfaction. The second point I would like to draw out is the new concepts that have been introduced into this staff survey. There's a couple of things. One is the scorecard. We use the scorecard to communicate our results to departmental level. So we've got 16 scorecards and an overall scorecard. The second concept is the EMPS, the advocacy question in the survey. We identified that separately as a measure, as a metric for overall staff satisfaction. And only answers one question: would you like to recommend the organization? I think that's an important question, and that sort of covers everything. If you're happy, you will recommend your organization, and that is what we would like to drive. Not letting loose the engagement piece, of course, but that metric is for us something that we intend to develop to become the employer of choice. You know, if you are recommended, then we will automatically be the employer of choice. And finally, a new concept is the feedback into action program that has staff engagement at its heart, involve the staff in the actions and the prioritization of the actions that we take on basis of that feedback. And that's a process that unfortunately we had to sort of curtail and pause because of COVID, because it involves close interaction with teams. But we have sort of introduced an alternative for the time being, which is a start, stop, continue exercise, which asks them to feed back to us as well. So there is some engagement, but not quite in the setup as we anticipated. I think that is it. We are going on with the staff survey as an important tool in our staff engagement process. So this year we will continue with quality health and carry on and build on what we have achieved this year. It is really for the board to note, for information, but also to seek active support for the new approach that we have taken in DSFS. And that is it. I'm happy to take any questions or comments.
Thank you very much, Dennis. I think it goes without saying that you've done very well to implement such wide-ranging, fundamental change whilst maintaining the level of engagement and staff satisfaction you have, and tells me that it's a great platform now for you to go forward and build, through building the culture you are, see all the improvements you richly deserve. And I think we see very early and positive signs of that in the magnificence of every member of DSFS staff's response to the COVID crisis. I think it's fair to say that as a trust, had we not had your leadership and the huge commitment and dedication of all your colleagues, that we couldn't have responded as comprehensively and magnificently as we have. And if anything goes out of today's board meeting, I think it's really important that our resounding applause to you and all of yours go back, because it's really been first rate. And to have achieved that in such a short time post incorporation is all the more credit to all of you. So very well done. So our comments and questions on your staff engagement report will be coming in that context.
Yes.
Is there anybody who would like to add to any of that? I think you can see a lot in the chat, Dennis, about here, good leadership, excellent results, really good result, stunning. I would like to add particularly to Sue's earlier comment about the Net Promoter Score. I think that's absolutely key. It's lovely to see, I mean, I'm going to say some modern practices, they're not modern, they're as old as the hills. But of course they're modern in the context of the NHS, and I look forward to us as a trust having some important learnings from you as our subsidiary, and I'm sure that interchange of good practice will serve us both well, but we will be definitely taking that away as a learning for us. And again, comments about the employee directors and that engagement and that sense of shared ownership of decision making is also being endorsed on the chat. Yes. And we will end on the comment there about brilliant results. So very well done, Dennis.
Thank you all.
You get what you deserve this life, and yours has been richly deserved.
Yes, thanks all, very much appreciated.
Thank you, Dennis. That brings us on now, please, if we make to the membership engagement strategy. John.
Yes, thank you.
And John, just to remind you, we absolutely have read it, take our word for it. So brief introduction, please.
Yes, of course. Yeah, just to say, it kind of seeks to kind of ensure to show that the trust recognise and the report reflects the need for a vibrant and engaged membership to ensure the high quality governance and services. So the strategy seeks to reiterate the Trust's commitment to its membership, understand their current picture and their challenges to the aspirations, and identify some of the actions to meet the challenges. The agreement of the strategy falls to the board, of course, but the Council of Governors have been absolutely involved in its development, and it's been recommended for approval to the board by both the Governors Involvement Engagement Committee and the Council of Governors itself. The idea is that the key aspect of it is obviously the implementation of the changes, and the hope is that it be considered by the Involvement Engagement Committee on a regular basis and come back to the board annually. You'll notice that the paper is not as prettified as it often would be if things have been slightly delayed due to COVID, but if approved, we'll obviously ensure that the final presentation is back to our normal standards for when it gets finally publicly published. I think everything else is in the report.
Well done. Thanks very much, John. Comments, colleagues, please. Beverly, and then Atul, please.
Thank you, Helen. Congratulations to John. I know we've been waiting for this. I'm sure governors will be delighted to see the strategy. I know it is mentioned, but I think it's something we need to give some thought to is the support for governors, because I know some governors have expressed some apprehension at interacting with members. So I really think we need to delve into that and think about what support we give to governors.
Thank you very much, Beverly. Atul.
Thanks, Helen. Yes, John, I mean, a great paper. I just wanted to re-emphasize, if you like, perhaps the role of the membership in wider public health issues. I mean, it's obviously importance in terms of governance, but I think it's a large constituency, people out on the ground in communities, and as you say, engagement, very important, but engagement also with an aim of trying to improve our understanding of public health, health inequalities, and getting messages out as much as receiving them from communities to ourselves.
Very important point. Thank you, Atul. Jeremy?
Yeah, thank you. And thanks, John. Just a couple of questions. One is, I didn't see any specific reference in here to the changed environment post-COVID, and I wonder whether that needs to be built in a bit more. And the other point is that there's reference to an implementation plan, and there's a draft implementation plan in Appendix A. I'm wondering where that's going to be signed off. Is that going to be at the engagement committee, or is it going to be signed off by us board?
Okay, thank you, Jeremy. Just to add to Jeremy's comment there, if I may, because my suggestion in summarising this item, John, is that we're going to be happy to approve the strategy subject to an amendment to section 2, which is where we are now, to add a reflection on the implications of COVID. Because I think it's going to be very difficult for us to sign off a strategy in July about membership engagement with just a footnote, oh, and by the way, we're 4 months into COVID. Not least of all, as I think partly it's fairly fundamentally shifted our relationship with our membership. We always knew that we had a good relationship with our community, and, you know, a testament is borne to that at every annual general meeting. I don't think even we realise the extent of the community support we have, and we've seen outpourings of that in various donations, contributions and other efforts to support our response to COVID. And I think it's really a great time for us to acknowledge and applaud that support, but also to reflect if that is how people feel about the hospital in wartime, if I can describe it in those terms, how we might better galvanise their support in peacetime. So I really would like if some additions could be made to section 2, and flowing from that, any augmentation of section 3. But that's not to in any way detract from the excellent work that's been done and a very good strategy, but I'm sure it could be strengthened in that context. Lee would like to add a comment on the new peacetime. Lee, please.
I just wondered, in the context of membership, Helen, that where some thinking is taking place about our members in the context of citizens living in an integrated care partnership structure. And I think for most people looking into the health and care space and the ragbag of engagement mechanisms we've got between health and wellbeing boards, local councils, what we do in terms of oversight of primary care, and membership with the community trust and membership with the mental health trust, perhaps the strategy is a bit silent on what might come next. We've got a very rich membership engagement structure as a foundation trust, but connecting it together with other elements of engagement in the broader agenda of health and well-being, perhaps there's some COVID referencing that might be helpful, and post-COVID referencing. If we were even more aspirational, perhaps trying to do some of that joining together might be helpful.
Yes, and as Judith Rees has mentioned in the chat about conditioning and helping patients orientate in a positive way for future changes to come. So those comments very much reinforce each other. So are colleagues content for me to summarise in that way, that subject to the changes around COVID and the helpful additions from both Lee and the comment from Judy in that regard, that we approve the strategy? Very good. Well done, John. Very good work. And with regard to prettifying it, I shouldn't worry at all. It didn't lose any of its impact from my perspective. I think it's much more important what we do than how it looks. So I shouldn't concern yourself about that. And of course, just by way of summary also, I think it's really important that we remember Beverly's encouragement to us to make sure that in terms of the implementation, governors are properly supported in reaching out to the membership. Yeah. So thank you very much for that. So that now brings us on, if we may, to the next section and item 9, which are the next steps in the strategy refresh. Angie, please.
Thanks, Helen. And you stole my introductory line earlier when you used we haven't got a digital strategy, we haven't got an organisational one that we heard yesterday. And interesting discussions today. I think we've touched on strategy, where we're going and what we need to do. There's 2 specific things I just wanted to highlight under this item. One of my colleagues who's on holiday in France today challenged us when we said we'd re-looked at the timetable because we'd had to pause our strategy refresh because of COVID. When you take a step back and think how much system work we've done, how much listening we are doing, reflecting we need to do more with our patients and our community, how much work we've done on recover and restore, then have we really paused it? So I think just that thought to set in context of where we're at. What we do want to do is go out wider now with the vision, mission, success factors and care values that we all had the opportunity to discuss at our meeting in June. And you'll see the version in front of you hopefully reflects some of the conversation that we had, recognising that these will never be perfect and never suit everyone at this stage, but we wanted to get them robust enough with all of our input and some of the input we've had from Leadership Assembly to go out wider to our teams. We're aligning it with the work that Dennis is doing, has been referenced earlier, and we've had some good suggestions from our teams about how we engage on some of this work. And you'll remember the stakeholder map that we all did back in January. That's our framework for going out and having some of the discussions, whether that's about the vision and mission in front of you, or those clinical service conversations that we discussed earlier. So it's for board to agree that they're in a state for us to continue that engagement today, please.
Thank you very much, Angie. If I might come to Sue first, please, and then I'll come to Jeremy.
Thanks, Helen, and thanks. And first to say, really exceptional document. I love the presentation and the look and feel and style of it, so well done. A couple of things from me, and Andrew, I hear everything you've just said, that it's a draft to now start going and engaging with, so it will no doubt evolve and change on the back of that feedback. The one thing that struck me yesterday when I was looking at this, and we did have a chat with the Neds as well, in our board development session, again we've talked a lot about the patient being at the heart of everything we do, and it struck me that in the mission statement, in the vision, and in the critical factors, it doesn't jump out at you. So it's in the under provide exceptional care, it clearly says we'll provide safe, high quality person-centred care, but it's not the first thing that you see. And I wonder whether there's something where we can kind of really amplify the fact that that's the point of us all being here. And I do appreciate we've talked about the difference between a patient and a person, because if you're thinking about health determinants and the wider system, you hopefully won't have any patients. But still, I think there's something in there, because that is ultimately where we are targeting. Also, when we were, when you do your could I explain this to my mum test, she features quite a lot today, my mum, doesn't she? She would definitely provide exceptional care, look after our people, support our communities and improve every day. I think we might think about whether the add value bubble is called something else. I completely get it, and I understand what we're talking about. It's kind of going beyond what we're doing, isn't it? And it's maybe about the role we play in the wider system. I would just kind of call it out as a possible space where, because I think the language is so clear and so real, and I just think that's the bit where it's not quite right. It would be my feedback on that. And as I don't want to say anymore because I don't want to wordsmith, that's not what today's about, is it? But those were kind of the main headlines for me, really. So probably where I'll go with the colleagues.
I wondered, Sue, if you wanted to share your thinking around statements of ambition around each of the bubbles, so that we've got an understanding of what it is we're trying to achieve before we get into planning.
Yeah, really good. Thank you, Helen. We did talk about that yesterday, didn't we? Yeah, because I think there might be a tendency, because this is what I think the exec team are very good at, is getting straight into the plan. And I think there's something about this, that the CSFs are there, the critical factors, but then to kind of say, if we know where we are today on that, what's our ambition position? And, you know, if you had a scale of 0 to 10, some of them we might say our ambition's 10 and we're already at 8. Others you might say we're only at 3 or 4. So our target and our key performance measures then of achieving on this strategy would be different. So I would like us to, in that journey that's in the deck that shows our steps to having this landed, I would like us to be clear about what's the ambition about each one, and then the how will we know when we've got there, what are our kind of proof points going to be and our indicators. And I think we should kind of try to hold ourselves to do that bit before we dive into the planning, because obviously the plan has to then meet those measures, and they will change what they as the years tick by. Will be kind of green and gold on some, and then we'll need to come back and track on the others. So yeah, thank you, Helen, for reminding me of that.
Thank you, Jeremy.
Okay, thanks very much, Helen. I want to make 3 comments about this, one of which is really much the same as what Sue's just said, which is I think it'd be helpful to be a bit more specific about where it is we're trying to get to. Be more concrete in saying this is the vision we have, this is what the trust is going to look like at some point in the future. Second point is that there's no clarity about the timescale here. We don't know whether this is a strategy for 1 year, 3 year, 5 years, whatever. It doesn't tell us that, and I think that needs to be rectified. And then the third point, which won't surprise anybody, is that I'm disappointed there's no mention of our environmental impact. I paraphrase the earlier comment. I think if we don't have an environmental strategy, we don't have a strategy. And we have discussed this in the past and said we need to build it in, and yet it seems to be missing from this. So I think we do need to include that somewhere, the importance of analysing and reducing our environmental impact as part of our overall strategy.
Thank you, Jeremy. Atul, please.
Thanks. I just a small point really. I wonder whether we can now drop the word refresh, because I think it probably doesn't do justice to the work that's gone into it. And this is now, I feel it's more than a refresh anyway. So just a little bit of semantics, but suggestion.
Thank you, Atul. Any further comments? Okay, well, thank you very much, Angie, for getting us to this position. It's really good that we have, and that we're keeping our eye as a board on the future. We've got 3,000 people who are managing the current situation, and I think we will be letting them down hugely if some of our focus wasn't on where it is we're going to get to. We think you've done a really good job in getting us to the point where we can now have a wider conversation with colleagues and stakeholders. And prior to doing that, we would encourage you to consider some of the language, particularly around the add value element, that you come out with a statement of ambition, perhaps in respect of each of the bubbles, so that we understand where it is we're trying to get to, and we're not at the mercy of a plan bringing us to a destination that is not set out in the strategy. That we add the green and climate elements that need to be incorporated, but that first and foremost, it's intelligible in terms of our commitment to patients and from a patient perspective. So it strikes me that should be relatively easily achieved, and we look forward to being able to take the conversations forward soon.
Thank you, and I just want to say thank you to Sarah Turner-Saint and Maria. And I was smiling when Sue said it and when Helen just said it, because you wouldn't believe the debates we had around the add value, and it didn't actually start as add value because I said that I can't even remember what the previous statement was. It didn't make sense to my mum. So thank you for all the comments and feedback, really helpful, and we'll get on an update. Thank you.
Very good. So thank you very much for that. We've already had the discussion of item 10 on Royal Primary Care, which we did earlier. So that brings us on, please, now, if we may, to the Green Plan, Lee.
Thank you, Helen. I just want to make 4 comments, really, before I open up to a bit more of a conversation. The first comment is just, I included these 3 quotes in section 1 from the King's Fund, because I thought they were quite a nice summary of quite how big a issue this is, quite what's left to go at in terms of goods and services and chattels that we get as a trust, which we've not done too well on nationally in the NHS, and just this trade-off we've got about, given how intensive the NHS is in its carbon consumption, there is a trade-off here about how we try and pursue a carbon reduction strategy around care outside hospital, as opposed to reducing the unit cost of carbon. So I included those 3 quotes in italics at the start of the paper quite intentionally, because I thought they were quite a neat summary of quite how big an issue this is for the UK, which I don't think we've addressed very well. The fact there's a lot to go at there in terms of the embedded carbon in the goods and chattels the NHS consumes that we've not managed to track down, and the fact that there is this tension there about quite how carbon intensive healthcare in hospitals is, and therefore there is a need to shift resources away. So it does reinforce some of the other things we're saying. So that was the first point I was going to make. The second point I was going to make was about this very stark table that there is on page 10, just about what we don't know yet about the embedded carbon in these other categories and how much more work we've got to do. And that table was included quite intentionally to sort of point out there is a key piece of work to do now for us locally and nationally to understand this a lot better, which is the first line item in the sort of work plan for this year. We are ever so slightly flying blind beyond our sort of core carbon consumption in terms of where we go to next. And the reason why the year 1 first bullet objective is improve the baseline of our carbon footprint, it is without that we are slightly stumbling around like a blind person in the dark about what will have the most impact. So I wanted to make that point. Second, the Green Plan response is we are doing some of this already, but Jeremy and I, as you would imagine, have been exchanging emails on this. And is it ambitious enough? You would imagine that repartee is taking place. So we're doing quite a lot of these things, but there's more to do. So just note that. But I think we've got a framework for the 4-year Green Work Plan that will refresh with those bullets in the first year that will make a lot more progress. And to be brutally frank, I don't think we've done this agenda justice, and I've found more time to get engaged with it, and there is a load more that we can do, but I'm happy to open up for a broad debate.
Thank you very much, Lee. I'm going to go to Jeremy, as you might anticipate, in the first instance.
Okay, thank you very much. Well, first thing to say is I'm absolutely delighted that we've got this item on the agenda. I've been calling for a proper discussion about our environmental strategy for a while. I am slightly ashamed of the fact that, having been calling for it for 5 years, it's taken us so long to get there. But nevertheless, it's really good to have this on the agenda. And thank you very much, Lee, for the work done in preparing it. I do think it's not as ambitious as it might be. I mean, we are an ambitious organisation. We want to run our affairs and deliver services in such a way that we're deemed to be outstanding, and I would incorporate a more ambitious approach to our environmental impact as being part of what it means to be an outstanding trust. I also think we're in danger a little bit of inappropriately resting on our laurels, in the sense that there is a claim, for example, that we are reducing our energy usage. And in fact, if you look at the data in the table on page 6, we're not reducing our energy usage. And the graph of showing the reduction in carbon emissions from energy usage, that's come about entirely because the national grid has become less carbon intensive, not because we've done anything. So I don't think we can claim that we've made a great success there. It's just that the electricity we're buying off the grid is less carbon intensive. Having said that, clearly the big issue for us and for other trusts is around the embedded carbon in the goods we procure. And I'm delighted to hear just now Lee highlighting the need to get a much better grip on that. And I think that should only be a precursor to then using that information to inform our decisions about procurement, because this has got to be much more than just a sort of analysis and spectator sport. We've got to not only observe and understand the matter, but actually do something about it, so that we can achieve the necessary reductions in carbon emissions. And of course, we do need to remind ourselves that there is a national legal obligation not to hit an 80% reduction, but to hit net zero by 2050. And many people argue that that's actually too late. We need to be hitting net zero much quicker. And clearly, we're only going to do that if the whole supply chain, the rest of the health and social care economy, and all of the pharmaceutical industry and so on and so forth that produce the goods that we procure, if they become net zero. But they are not going to do it unless and until we provide the pressure as part of the demand of that. And of course, I recognise completely that that's not something that Chesterfield Royal Hospital can do by itself. It has to be done in concert with other trusts, but I don't see any reason why we shouldn't be at the forefront of that. Overall, I'm very pleased that we've got this here. I do think we could be a bit more ambitious about things. I do think we could be more ambitious about wanting to analyse and work on procurement. I think there are other things that aren't mentioned here, like the food offer we give in our catering supplies. I mean, I don't see any reason why we shouldn't, for example, have at least one meat-free day per week, which would reduce the carbon footprint of our food offer, and also begin to send out a message to staff and patients that we're taking this seriously. I think there's much more that we need to do in terms of engaging staff as to why we think this is really important. And as always, there's more we can do on the transport and travel stuff. But I'll leave it at that for now. I'm happy to pick up on some of these points, perhaps by correspondence out of the meeting.
Thank you, Jeremy. Atul.
Thanks, Helen. Lee, I'm glad to hear you were saying that you're getting into this a lot more as well. I mean, I feel this is personally a very important issue, and there's a sort of certain lack of urgency about it. I go into this very enthusiastically, but by the time I read the report, I was really quite deflated about it. And it's important, as Jeremy just said, to get people on side and to get that sense of enthusiasm around this, and the fact that this is a climate emergency. It's a different kind of emergency to COVID, but nonetheless, and possibly even much more long-lasting disbenefit to our way of life as a civilization. I don't want to overstate this, but I think it is something we have to inspire people. We have to sort of get that spark across. Now, yes, I mean, we could look at a whole range of things and then decide what's most effective and so on. But it is a bit like, developing the COVID vaccine. You've got to do a lot of things together, and in the hope that most of them or some of them will work. And actually, when I attended the sustainability seminar, I was really pleased to see that there are so many solutions, technical solutions and ideas out there that you could literally lift and plonk in and try out and see how effective they are. So my fear is that by the time we get it all right on paper, and more time will have gone, So I'm really for, doing short, sharp things which are demonstrably beneficial, and then we can take further steps beyond that rather than overarching strategy. And I don't think we need to wait for the centre to tell us what the NHS Green Plan is. There's plenty that we are doing, we can be doing a lot more to that. So just getting that sense of energy into this subject.
Thank you very much, Atul. Sue.
Thank you. Yes, just back to echo what Atul just said at the end there. Thank you for the paper. As we've all said, it's great to have it here now for consideration. It is long though, and it's quite, I'm not an expert in this at all, and I did find myself kind of struggling to get the sort of so what of what it was saying. So I think it would be helpful to have a kind of upfront, what is our ambition on this? To Jeremy's point, we are ambitious, and it could do with having that shot of energy up front that says, why do we care about this? What are we doing about it? What are the headline areas? And then, because it is quite massive and it feels a bit impenetrable, and some of it's very long term, whether we could have the kind of, what are the quick wins that we're going to nail this next 6 to 12 months? What are the longer term things that we're putting things in place with? And what is it, that are sort of slightly outside our control, but we can influence? Because I think to chunk it in that way might be helpful. Because also for staff and patients is to be able to say, well, what can I do? What could I play? And I think chunking it in that way might help. And then just one small point, which is on section 4, where it says the 4-year green work plan. I think we should probably call it a 3-year one, because year 4 says, look at what we've done and do some more planning. So I think it's probably a 3-year plan, isn't it? So that was all, but thank you for the paper.
Thank you very much for those comments. So I think, Lee, in summary, it would be fair to say we're delighted to have one. And by your own admission, it's not yet ambitious enough. And in much the same spirit as we had the scoping discussion for the RPC strategy, I hope we've been helpful today in setting out what it is we'd expect to see in a kind of final green strategy for board. And hopefully that gives you a good chance to come back with a further iteration. I've loads of hands flying up and down, but I think they're probably just people who've already spoken, maybe kind of playing with a button or something. So I'm assuming that we've done on that item. Again, Angie, it'd be helpful to know, when can we expect a further iteration?
I'll be guided by Lee on that and Jeremy on that one. Sooner the better in terms of fitting everything together with strategy and timescales. But Lee,
I'll try and find out when is a likely date for the publication of the National Net Zero Plan, because some of the things I think we'll need on procurement will be dependent on that. So I think some of the under ambition is based on some of the national support we'll need, which isn't an excuse. I think it's a factual statement. So if that's going to be 1 month next Sunday, I think we do something quicker. If it was going to come out on October the 1st, we could do it in the October board. So I'll just see if I can sense the runes of when the NHS Net Zero Plan is going to come out, because it'd be nice to have that in our clammy midst to go, this is the national support we're likely to get.
It would, but it'd also be fair to put you on notice, Lee, that if it's not back soon, Jeremy won't feel it's only taken him 4 years. He might feel it's taking him 44. So you need to come back to us sooner rather than later. Thank you very much. Now, item 12 are a number of very important consent items, and in the absence of having been notified in advance, I'm assuming that the board are content to approve the recommendations therein. So thank you for that. That brings us on then to any other business. Are there any items of AOB? No. There are some items for information and consequently for noting at agenda item 14. That then brings us on to the date of the next meeting, which seems like eons away, but I'm sure it'll be upon us in no time, which is the 30th of September. And it's our intention at this point in time to do that via Teams, but we will advise if there's any changes closer to the time. And then that brings us, before we do the review of the meeting, to a couple of questions we've had from members of the public in quotes, namely Judith Rees, our governor colleague. And Judy made a couple of important points. She was a bit surprised that the Register of Interest only offers significant rather than full assurance, which I've got some sympathy with. I mean, I don't know if it says significant, because you can never legislate for somebody having forgotten to tell you that something has changed. But I would ask you to take that one away, John, and have a think about it.
Yes, I think it's probably just it's an oversight when we did it. I think it does give full assurance for what we know at the time, and that's the only basis we can do, so we'll amend that.
Thank you very much. And the other point Judy made was on the back of a discussion early on in the meeting about, we were talking about people of protected characteristics and vulnerable patients and service users. By way of example, those who are hard of hearing, it was on the back of the audiology item story, and about our use of masks and other items of PPE, and whether or not that is being tailored to the requirements of particular patients. So if we could, I know I have seen some adjustments that have been made. There's a very active and vibrant dialogue around all of that going on the Chesterfield Royal Staff Facebook page. So I know that's in train, but I think it'd be really good, Angie, if some of our external communications, we might also explain that. And I think that's been a helpful reminder from Judy. So thank you for that. Feedback, how was it for you, as they say, or in the words of the Great Prayer, what have we done or failed to do, or even perhaps more pertinently in terms of leading the Chesterfield way, have we had a good meeting? Don't be shy, you're not usually. Sarah, your first meeting around the board table, so that gives us adequate reason to go to you first, and you're going to be next, Dennis, so get your thinking cap on.
Thank you, Helen. Yes, really good for me. Obviously, this is Lynn's last meeting, so I was really keen to take that final opportunity to learn from the master. So really helpful and really good conversations. I think there is an opportunity which you've just done in terms of linking some of the protected characteristics to the patient story and looking at that wider piece of work. So I think that all joins in together very nicely. So yes, thank you from me.
Very good. How is it for you, Dennis?
Put me on mute. Very informative, very good. I was pleasantly surprised in terms of that COVID was not covering the whole agenda, you know, because COVID is important and we are dealing with it as we are. But, you know, there are things we are starting to move further ahead with recovery and restoration and other things as well. And that came to the fore, and I was pleased with that. Thanks.
Very good. Thank you. Jeremy?
No, nothing to add, really. Thank you.
Oh, sorry, you must have been having a flapping hand. Lee?
I think the use of consent items works well, and I think it's enabled us to focus on the right things. So I think that's a big positive. But to balance that up slightly, perhaps in terms of public accountability, the good governance section and the richness of that report and just the feedback from the committee chairs, if I was looking externally from the public around assuring the organisation in its full breadth of activity and the depth of that reporting, question mark, is it enough? That's not to say I think it's the right thing, but does it need to be supported and accompanied with something more, question mark?
Thank you, Lee. Sue?
I was just going to reflect what Dennis said, actually. I think given that we are still in the grip of COVID and it obviously will take a lot of everybody's waking hours, I think it was great to have an agenda with so much forward-looking stuff around strategy refresh and looking at, you know, going forward, how we measure, you know, patient experience in light of our new world and so on. So just to say, I think it was a well set out agenda. And some good discussions. I do echo a bit what Lee said, actually, would be good to get any feedback on that, because I think those of us who've been involved in the detail feel assured, but whether people looking in would think that is a good test question, I guess. Thank you.
Yeah. Okay, thank you very much. Oh, that is for you for real, Jeremy.
Excuse me, for real. Yeah, I just wanted to pick up on that point, which I think is really important. And I think a lot hinges on how we minute that section, because you know, we need to make sure that the assurances being given by us as chairs is documented somewhere. And that the only way in which that's going to be done is now in the minutes, because we're not providing written reports.
Thank you very much, Jeremy. Angie?
I was just, I'm reading Judy's comment because I was just reflecting on the question we set ourselves around, are we a good board, and the engagement discussion, and reading those points on the agenda and thinking, are we and have we? And it's probably 50-50 at the moment. So I think some good discussion though that challenges on some of those points around how we're engaging with our patients and listening to feedback. So I think just not to lose sight of that focus that we said we'd had and how we're learning from that. I thought the good governance section was really good summary by the chair committees, but that might be because I've been in those committees apart from one. So as Sue says, you have the detail, but I think it's a really good question to keep testing ourselves on how that's working. And just my last comment, I really will try harder next time to unmute Helen when she needs a meeting.
I'll have to get you a spangly top. I mean, just to make a brief comment about that issue of committees. I mean, at the end of the day, we're all grown up, fully fledged directors of this trust. So the purpose of that item is to be assured. So if you're not assured on the basis of the report, you've got a tongue in your head and plenty of opportunity to ask however many questions are necessary until such time as you are assured. So I, for one, would like to persevere with that for a while on the basis that we all have to act responsibly rather than produce any more paper. But I think it's a good point that we keep it under review. I'm also grateful to Angie for talking about the focus we had on engagement, and I'm particularly gratified to see Judy's comment about this being one of the most engaging meetings in dealing with the issue of how we're really experienced by patients, especially those in the community. So it's lovely to have that confirmation that was that visible and clear to you too, Judy, for that. And I think it's lovely also to hear the feedback that we're appropriately focused on the future. As a trust, we have had 138 patients die in our care due to COVID, which is a shocking toll for them and their families. But as we've said many times at this board previously, our success through this period in the fullness of time will not just be measured by COVID casualties, it will be measured by total mortality for the period with which the country has been experiencing COVID. So it's really important that as a board, that is what our eye is on in terms of those full range of services and their timeliness and efficacy of clinical outcomes. And good about the agenda structure comment too, Atul. And before I pass across to you, Lynn, and I will, but not before I have reiterated the board's thanks and appreciation to you for everything you've done. You've been an outstanding colleague. It's been a pleasure and a privilege for us to have had the opportunity to work alongside you. And whilst we appreciate you might be drawing elements of your pension, we don't for a moment consider you retired. We're very conscious of the fact that you're on a career break and enjoying the opportunity to have more time with your growing girls. And we will watch your career progression with interest, which we feel sure will continue on its current trajectory when the time is right for you. So you go with our very best wishes and huge gratitude and appreciation. And the last word to you, Lynn.
Helen, thank you. I've had so much thanks and best wishes, but that's really helpful. What I wanted to comment on was that we start every board meeting with our patient story. And I think one of the things I've asked my team and Sarah to take forward for the future is thinking about how we do enable our patients and their families to engage in that element of it, which we weren't able to do today. Apologies for that, because I actually think we lost something by not having the actual patient on in the story. although Debbie did a good job, but nonetheless. So I just want to say we are looking to take that forward. But having been a board member here for 6 years now, I have really seen the strength of the board and them making a difference to the impact of patients in the hospital. And I think, you know, since Atul and Sue and others have joined the board, I can only see that has strength. Mentioned it. Sue, your contribution today was really great. So I think that's really important to keep us as execs focused on that.
Well done.
Well,
it was about the patient focus and encouragement to us as Lynn moves on. That's very much front and centre of our deliberations, which I'm sure it will continue to be. So thank you all very much. I suggest we dial out, and for those who are involved in the next meeting this afternoon, if you could dial back in promptly for 12:30, please. Many thanks. Take care. Bye-bye.